Imagine you're an ER doctor. A patient is brought in after falling off a ladder.
Right. Pretty standard trauma.
Exactly. And they're perfectly awake. I mean, they're having a totally normal, coherent conversation with you and the paramedics. Then, like an hour later, they suddenly collapse and die.
Oh, wow.
Yeah. What invisible force just killed them? Welcome to this custom-tailored deep dive. Today, we are cutting through a massive stack of clinical guidelines and critical care nursing protocols. We're specifically looking at the high-stakes management of severe burns, strokes, and traumatic brain injuries.
And, we're really pulling back the curtain on how medical teams keep a human being alive when their biological systems are actively collapsing.
Because at first glance, a burn, a stroke, and a head trauma, they look like completely unrelated emergencies, right?
Yeah, totally. You have a surface injury, a vascular event, and blunt force trauma. But the hidden thread connecting all of them, the actual minute-by-minute crisis that critical care nurses and doctors are managing, is physics.
I love looking at it this way. If you look at the blueprints for, say, a massive high-tech skyscraper, the most complex part isn't the steel framework. It's the plumbing and the HVAC.
Oh, absolutely.
You have this intricate, deeply interconnected network of pressurized pipes, fluid dynamics, and electrical sensors. If a main water line bursts on the 40th floor, the pressure drops everywhere, the electrical grid shorts out, and suddenly the entire building is compromised.
Right. It becomes a localized failure that instantly cascades into a systemic crisis. And medical professionals, they are essentially doing high-stakes biological engineering.
Wow, biological engineering.
Yeah, I mean, they're manipulating hydrostatic pressure, managing fluid shifts, and anticipating biochemical cascades just to keep your body's hydraulic and electrical systems online.
Let's start by looking at the outermost layer of our biological building, the skin.
The ultimate barrier.
Yeah, exactly. It's not just a wrapper. It keeps our internal fluid pressure stable. So when that barrier is violently destroyed by a burn, the internal fluid dynamics just go absolutely haywire.
They do. And to understand the medical response, we first look at the depth of the destruction. I mean, we all know what a superficial sunburn feels like.
Sure, first degree, painfully annoying.
Right. But when you get into third degree, or full thickness burns, the entire depth of the skin is destroyed. The tissue becomes leathery or even charred.
God, that sounds awful.
It is. But paradoxically, the patient might not feel extreme pain in those specific areas because the nerve endings themselves have literally been incinerated.
Wait, really? The nerves are just gone?
Yeah, completely gone. And fourth degree burns go even further, extending completely through the fat to expose muscle, tendon, or even bone.
But the immediate medical priority in the ER isn't actually the skin itself. It's the ABCDE approach.
Yeah.
And A is airway.
Always airway first.
Right. The sources highlight that inhalation injury is a massive killer here. Medical teams are immediately looking for soot in the mouth or like singed nasal hairs.
Because if you inhale superheated air, the soft tissues of your airway will swell incredibly fast. We're talking about the airway completely closing off in a matter of minutes.
Just swelling shut.
Exactly. So if a nurse hears a hoarse voice or a high-pitched wheezing, they call it stridor, the protocol is to secure that airway with a breathing tube immediately, long before the swelling makes it physically impossible to get a tube down.
Okay, you secure the airway, the patient can breathe, but now the skin barrier is gone. What happens to the vascular system? Because the sources describe the body's blood vessels becoming incredibly leaky.
Oh, incredible.
Plasma just starts weeping out of the vascular system into the surrounding tissues. You are literally bleeding out internally, just without the red blood cells.
Yeah, we call this burn shock. The blood volume plummets, blood pressure tanks, and the major organs are suddenly starving for oxygen.
So how do you fix that?
To fix this, medical teams have to pump massive amounts of fluid, usually something called lactated Ringer solution, back into the patient. And they use a tool called the rule of nines to rapidly estimate the total body surface area that has been burned.
I noticed how practical this is in the sources. In the chaos of an ER, doctors don't have time for complex geometry.
No, definitely.
So the body is mentally divided into 9% chunks. But for scattered burns, they can literally look at the size of the patient's own palm, which represents roughly 1% of their body surface area, and use that visual to mentally map the damage and calculate the fluids needed.
It's incredibly clever, and that rapid calculation feeds directly into the Parkland formula. A severely burned adult might need 15 or 20 liters of fluid in a single day.
20 liters.
Yeah. That is like pumping 10 large soda bottles directly into their veins just to keep their kidneys from shutting down.
Okay, let's unpack this, because the timing protocols on those fluids are wild. The rules state that exactly 50% of that massive volume has to be pumped in during the first 8 hours. Right.
But wait, the 8-hour fluid clock starts at the time of injury, not arrival at the hospital.
That's right. The clock starts the second the burn happens.
What happens if they are delayed getting to the ER? Let's say they arrive 4 hours after the fire. Do you only have 4 hours to pump in half a day's worth of fluid?
That is the terrifying reality of burn care. If the patient is delayed, the medical team has to infuse that fluid at a drastically higher rate just to catch up to the timeline.
Wow.
Because every minute the vascular system remains empty, organ tissue is literally dying.
But you can't just blindly pump 20 liters of fluid into a human being without consequences.
No, you run straight into the dual dangers of under-resuscitation and over-resuscitation.
Yeah.
If you don't give enough fluid, you trigger kidney failure.
Right.
But if you give too much, you trigger fluid creep. All that excess fluid leaks into the tissues, causing massive, rigid swelling. In a limb, this creates compartment syndrome, where the swelling actually crushes the blood vessels and cuts off circulation entirely. So it's a massive tightrope walk. How do they even know if they're getting it right?
Well, to navigate this, nurses don't just watch blood pressure. The ultimate gold standard to know if the fluids are actually reaching the organs is urinary output.
Interesting.
Yeah, if the kidneys are producing 30 to 50 milliliters of urine an hour, it proves the biological plumbing is actually working.
Speaking of biological plumbing, there's a bizarre quirk in the protocols about pain medication. Obviously, burn victims are in agonizing pain,
Unimaginable pain, yeah.
but the sources are incredibly strict about this. Pain meds like morphine or fentanyl must be given intravenously. You cannot give them via a standard intramuscular shot. Why is that?
This goes directly back to the lack of blood volume. During burn shock, the body goes into survival mode, right? It shunts whatever blood it has left to the vital organs, the heart, the lungs, the brain.
Leaving the rest of the body dry.
Exactly. It completely cuts off blood flow to the muscles. So if you inject morphine into a shoulder muscle during this phase, there is no blood flowing through that muscle to pick up the drug. It just sits there.
And if the nurse thinks, well, the patient's still in pain, I'll give another shot.
That second dose just sits in the muscle too.
That's a disaster waiting to happen.
It is. Then, hours later, when those massive IV fluids finally restore the blood volume, perfusion returns to the muscles all at once. Every single dose of accumulated morphine is flushed into the bloodstream at the exact same time.
Oh my.
Yeah, it creates a delayed, potentially fatal overdose. That is why every medication must go straight into the vein where it is instantly utilized.
That is a terrifying mechanical trap.
Hmm.
Now, the sources contrast these heat burns with cold thermal injuries, like frostbite. And the surgical approach is totally opposite.
Night and day.
For severe thermal burns, surgeons will often cut away dead, charred tissue immediately to prevent infection. But for frostbite, there's a surgical maximum freeze in January, amputate in July.
Right, because frostbite causes microscopic ice crystals to form inside the cells, destroying the tiny microvasculature.
It's freezing the pipes.
Exactly. And early on, it is notoriously difficult to tell exactly which tissue is permanently dead and which tissue might eventually recover as blood flow returns.
So if a surgeon operates too early, they risk amputating healthy tissue.
Precisely. So they endure a painstakingly slow process, waiting weeks or even months for a clear, undeniable line of demarcation to form between the living and the dead tissue.
That sounds grueling. So with burns and frostbite, the crisis is the fluid leaking out of the vascular system or the vessels themselves being destroyed.
Right.
Let's move our focus inside the body, specifically to the brain. Here, the crisis becomes how fluid blood moves through the pipes. Let's talk about strokes.
In the realm of strokes, we are dealing with distinct vascular pathologies. The first is an ischemic stroke.
This is a classic plumbing blockage, right?
Exactly. A blood clot gets lodged in a cerebral artery, instantly cutting off blood flow to a specific section of the brain.
And the medical response is reperfusion, either busting the clot with a drug called TPA or physically dragging the clot out with a catheter during a mechanical thrombectomy.
Right. Now, the second type is a hemorrhagic stroke, which is a burst pipe. An artery ruptures and blood spills directly into the brain tissue.
That sounds catastrophic.
It destroys the tissue it touches, but it also creates a massive spike in pressure inside the skull. The treatment here is often surgical, literally opening the skull to evacuate the pooled blood.
But what about when the pipe is just weak? I've always heard aneurysms are like ticking time bombs.
A cerebral aneurysm is exactly that. It's a weakened, ballooning area on an artery wall. It's bulging under pressure, but hasn't necessarily burst yet.
Okay.
If it does rupture, surgeons will either place a tiny metal clip across the neck of the balloon to seal it off, or thread microscopic platinum coils inside the bulge to force the blood to clot and seal the leak.
Here's where it gets really interesting. The protocols for managing a patient's blood pressure reveal what the sources call the paradox of stroke care.
It's a massive paradox.
Let's use a garden hose analogy. If you have an ischemic stroke,
Right.
the blockage in the hose,
Wow.
the grass on the other side, the brain tissue is dying. So the nurses actually allow permissive hypertension.
Yes.
They will let the patient's blood pressure soar, sometimes up to 220 over 120. They are deliberately cranking the water pressure as high as safely possible to physically force blood past the clot and save the dying brain tissue.
What's fascinating here is how this dictates the minute-by-minute reality of a neuro-ICU nurse. Because if you take that exact same blood pressure 220 over 120 and apply it to a patient with a hemorrhagic stroke,
It's lethal. Their hose is already leaking. If you crank the pressure on a leaky hose, you just flood the yard faster.
exactly. In a hemorrhagic stroke, the absolute priority is aggressively lowering the blood pressure to stop the bleeding.
That's wild.
You can have two patients in adjacent rooms. For patient A, a systolic blood pressure of 180 is a medical victory. For patient B, that exact same blood pressure of 180 is a catastrophic emergency.
So a single spike or drop in pressure can instantly flip a stable patient into a critical decline.
In a heartbeat.
And with aneurysms, there's this hidden secondary threat called vasospasm. The surgeon goes in, they clip the ruptured aneurysm, the pipe is fixed. The patient wakes up and seems fine.
What the?
Yeah, 3 to 14 days later, the blood vessels surrounding the surgical site can suddenly and violently spasm, clamping completely shut.
It is a delayed ischemic event. The presence of free-floating blood outside the vessels from the initial rupture is highly toxic and irritating to the exterior of the surrounding arteries.
So the blood itself causes the arteries to freak out.
It causes them to constrict so tightly that they cut off their own blood supply. It's a profound tragedy because the patient can survive the initial rupture only to suffer a massive, debilitating stroke 2 weeks later.
Oh, that's devastating.
To prevent this, nurses administer a calcium channel blocker called nimodipine. It relaxes the smooth muscle in the cerebral arteries, preventing the spasm. And it has to be given on a religiously strict schedule.
Because missing just a single dose during that 14-day danger window can trigger the spasm.
Exactly, you cannot miss it.
We've covered the fluid leaking out in burns and the fluid moving through in strokes. Now let's look at the container itself. What happens when excess fluid or pressure builds up inside the skull?
Because unlike an arm or a leg, which can stretch and swell, the skull is a rigid, closed box.
Right. Let's look at traumatic brain injury, or TBI, and increased intracranial pressure.
With traumatic injuries, we first analyze the mechanism of injury. The brain is essentially a soft, gelatinous organ suspended in fluid inside a hard bone vault.
Like jelly in a jar.
Good analogy. If you are in a car crash and hit the steering wheel, your skull stops suddenly, but your brain keeps moving forward. It smashes into the front of the skull, then rebounds and smashes into the back.
Ouch.
That creates bruising on opposite sides of the brain, known as a coup contre coup injury.
But if the impact involves a twisting or spinning motion, it causes something entirely different.
Right, rotational forces cause diffuse axonal injury, or DAI. Instead of a localized bruise, the brain tissue actually shears and twists, physically tearing the microscopic nerve fibers across the entire brain.
And the sources say that's often invisible on a scan.
Yeah, it's a devastating injury that is often completely invisible on an initial CT scan, but it leaves the patient in a profound coma.
The sources draw a really sharp distinction between the primary brain injury and the secondary brain injury. The primary injury is the mechanical damage at the exact moment of impact.
The initial trauma.
Right. The skull fractures, the nerves tear, it's done. It's irreversible. But the secondary injury, well, that's the biochemical cascade. That's the swelling, the edema, the lack of oxygen that develops over the next hours and days.
And the entire purpose of the neuro-ICU is to stop that secondary injury. To do that, they have to master the Monroe-Kelly doctrine.
Monroe-Kelly.
Yes. This concept states that the skull is a rigid box containing exactly 3 things: brain tissue, blood, and cerebrospinal fluid, or CSF.
Just those 3.
That is it. Simple physics dictates that if the volume of one of those components increases, one of the other components must be physically pushed out, or the pressure inside the box will skyrocket.
And it's not just trauma that causes this closed box crisis.
Yeah.
The sources point out that meningitis does the exact same thing, just through a biological mechanism.
Right.
Meningitis is an infection of the brain's lining, but the real threat is the inflammation and the pus.
The infection creates a thick inflammatory fluid. This fluid physically clogs the arachnoid villi, which basically act as the tiny drains that normally absorb cerebrospinal fluid back into the bloodstream.
So the drain is completely clogged, but the faucet is still running.
Precisely.
The CSF keeps building up, the brain tissue swells from the inflammation, and the pressure in the closed box goes through the roof, which leads to the ultimate terrifying endpoint: brain herniation.
Herniation is the brain seeking the path of least resistance. When the pressure inside the skull becomes too great, the brain tissue literally has nowhere to go but down,
Toward the neck.
toward the only opening in the skull, the foramen magnum, where the spinal cord exits. The brain tissue is physically squeezed and forced through that tight opening, crushing the brainstem in the process.
And the brainstem controls your automatic breathing and your heart rate. So if it gets crushed, it's over. Which brings me back to the scenario from the beginning of our deep dive.
The talk and die phenomenon.
Yeah. How is it physically possible for someone to fall, seem perfectly fine, talk to the paramedics, and then suddenly collapse and die an hour later?
It is entirely due to the physics of the closed box. Usually this is caused by an epidural hematoma. That's a torn artery pumping blood into the space just inside the skull.
Okay.
The patient is awake and talking because the brain tissue itself wasn't severely bruised in the fall. But that torn artery is acting like a running hose, creating a growing pool of blood that slowly compresses the healthy brain.
They're literally bleeding into the closed box.
Exactly. For a while, the body compensates by pushing out spinal fluid to make room. The patient feels fine.
But the very second that extra space runs out,
The pressure spikes vertically. The brain shifts, herniation occurs rapidly, and the patient goes from conversational to a coma in a matter of minutes.
wow. So to fight this, medical teams focus on a metric called cerebral perfusion pressure, or CPP. It is simply your mean arterial blood pressure minus your intracranial pressure.
Right. It calculates how much force the heart is using to push blood up to the brain, minus how much pressure inside the skull is resisting that flow.
So how do they manipulate the contents of the skull to fix that math? Because you can't just take the brain out.
No, you can't. But they will drill a hole and place a ventricular drain to physically siphon off excess spinal fluid.
Relieving the pressure directly.
Yeah. They will also administer osmotic diuretics like mannitol. These literally pull water out of the swollen brain cells and into the bloodstream to be flushed out by the kidneys.
That's brilliant.
They might even intentionally hyperventilate the patient on a ventilator.
Wait, hyperventilate. Why?
Because blowing off carbon dioxide causes the blood vessels in the brain to constrict, which shrinks the total volume of blood inside the skull and rapidly drops the pressure.
So we have all these unseen pressure changes, the brain swelling, the blood pressure spiking, the fluid shifting, but you can't leave a patient in a CT scanner 24 hours a day to watch this happen.
Right, that's impossible.
How do ICU nurses actually spot a closed box failure before the brainstem is crushed?
They rely on rigorous serial scoring systems, clinical assessments performed every single hour.
Like clockwork.
The two most prominent are the NIH Stroke Scale and the Glasgow Coma Scale, or GCS.
The sources mention the NIH scale is unique because it's counterintuitive. A score of 0 means no stroke symptoms. A higher score, up to 42, indicates catastrophic impairment across vision, language, and motor strength.
While the Glasgow Coma Scale measures global consciousness, it ranges from 3, which is deep coma, to 15, which is fully awake. There's a clinical rhyming maxim here, GCS of 8, we intubate.
Meaning if the score drops to 8 or below, the patient has lost the fundamental ability to protect their own airway.
Exactly. But the sources also spend a lot of time on how to interpret the specific physical movements on the GCS.
Right.
The motor response tells you exactly where the brain is damaged. If you apply a painful stimulus, like a sternal rub, and the patient reaches up to push your hand away, that is a purposeful movement.
The higher cognitive functions are still intact.
Yes, but if they respond with decorticate posturing, where the arms rigidly flex and pull inward toward the core, that indicates severe damage to the cerebral hemispheres.
And then there's decerebrate posturing, where the arms rigidly extend outward and turn away from the body. I want to make sure I understand the biology here. They aren't just flexing muscles, are they?
No, not at all.
The higher brain functions have been so damaged that primitive lower brainstem reflexes are taking over. The brain is essentially powering down to its most basic, archaic circuitry.
That is exactly what is happening. Decerebrate posturing is a catastrophic sign that the damage has reached deep into the brainstem.
So what does this all mean? Why do we care about a specific number on a scale? The sources emphasize the two-point rule. In the neuro-ICU, a shift of just 2 points on these scales, say, dropping from a GCS of 14 to a 12, isn't just a minor fluctuation.
Not at all.
It is a massive, blaring siren requiring immediate intervention.
If we connect this to the bigger picture, it's because herniation is a process. It is a cascade, not a sudden lightning strike.
Yeah.
The earliest red flag that the closed box is failing isn't a dramatic drop in heart rate. The absolute earliest sign is a subtle change in the level of consciousness.
Just a slight change of behavior.
Exactly. The patient becomes just slightly more lethargic, or when you shine a light in their eyes, one pupil is slightly more sluggish to react than the other.
Because the swelling brain is just starting to physically press against the third cranial nerve, which controls the pupil.
You got it. Those tiny incremental physical changes are the early warning system. By the time the late signs show up, like Cushing's triad, which is a skyrocketing blood pressure combined with a plummeting heart rate, you are almost out of time.
The hourly scales are how we catch the crisis while it is still preventable.
Precisely.
When you zoom out and look at all of this together, whether it's frantically calculating and replacing 20 liters of fluid after a severe burn, precisely manipulating blood pressure like a garden hose during a stroke, or managing the brutal mechanical space inside the rigid box of the skull after a trauma-critical care, is an absolute testament to both meticulous human vigilance and the sheer stubborn resilience of our biology.
It really is. It drastically shifts your perspective on what medical care truly is at its extreme limits. It is active, hypervigilant physiological management.
It definitely gives you a profound appreciation for the doctors and the ICU nurses who are turning these dials and keeping the body's hydraulic and electrical systems online when they're actively trying to fail.
Yeah.
But before we wrap up, I want to leave you with one final, slightly provocative thought about something we briefly touched on: cerebrospinal fluid.
Ah, the vital fluid inside the closed box.
Right. The sources note that the body produces about 500 milliliters of this fluid every single day, but the brain only holds about 150 milliliters at any given time.
So it's constantly cycling.
Exactly. That means your body is completely replacing and flushing the brain's fluid environment several times a day. It is a continuous hydraulic flush designed to clear out metabolic waste from the neurons, which makes you wonder, what happens to this deeply essential waste clearance plumbing system as we age?
It's a great question.
Or, more importantly, what happens when we don't get enough sleep? Is there a hidden plumbing system in our brains that, if we keep it flowing, holds the key to long-term neurological health, like preventing Alzheimer's or dementia?
This raises an important question at the frontier of neurological research. If the system doesn't flush efficiently, the biological waste simply accumulates.
So the next time you look up at a towering, complex skyscraper, don't just admire the glass and steel.
Yeah.
Think about the invisible, pressurized systems running behind the walls, keeping everything functioning, because you're walking around in one every single day.